Chapter 28's topic is embryology and pregnancy. So as you know, in last chapter we talked about the male and female gametes separately. So we're going to look in this chapter at what happens when they unite and the changes that the mother undergoes during her pregnancy, and also what happens during the period of embryology. So pregnancy obviously are the events that occur from fertilization until the infant is born, and undergoes a few name changes. So starting from fertilization until 8 weeks, this what is called a conceptus, which is the developing offspring, term is an embryo, whereas when we go from 8 weeks into the birth, this is called the fetus. So you guys might have heard these two terms. They're not interchangeable, so the fetus comes after the embryologic period. So before we even get into that, we need to talk about what happens during the process of fertilization. So remember that the sperm are taking a trip to find the egg, and as your text and as the PowerPoints list, there are some things that happen that prevent sperm from, so some kind of roadblocks to sperm getting to the egg, such as maybe they don't even make it through the vagina, they might be destroyed by the acid of the vagina, they might not make it through the cervix. The ones that do make it into the cervix and into the uterine cavity are destroyed by the immune system cells of the female, or maybe they choose the wrong tube to go down. So out of the millions that are ejaculated, only a few thousand generally reach the uterine tube. So the sperm use a chemical trail, an olfactory receptor that they have, to follow a chemical trail released by the egg or the surrounding cells that literally will smell their way to the oocyte. So once they get to the oocyte, they will approach, obviously, which is the first step. And when they get to the outer layer, which is the white layer there, it's called the zona. Well, first of all, they weave their way through the outer layer, which is called the corona radiata. Once they get through that layer, then they reach the zona pellucida, which is the white. The zona pellucida is a hardened layer, so they have to literally bind themselves to that layer. They will use their acrosomal enzyme. So we have a reaction called the acrosomal reaction. The acrosomal reaction will be important for dissolving the wall. So to dissolve the wall in order to clear a path for the nucleus to be injected into the inside of the oocyte. So once they are able to, So once they bind to these receptors down here, so these little triangle-shaped things, these are receptors. Once they bind to the oocyte's sperm receptors, then we'll see a fusion. The sperm and oocyte plasma membranes will fuse together, which is what we see right here. And so when those things fuse, then the sperm nucleus, remember that's the whole point of this, the sperm nucleus can be injected into the inside. As this is happening, you see this kind of blue reaction that's taking place here. This is called the cortical reaction. So there's two reactions you need to remember here. One was the acrosomal, two is the cortical reaction. And what this does is it hardens the entire membrane all the way around the oocyte to prevent further sperm entry. So it's called polyspermy. So when the first sperm delivers its nucleus, then the entire oocyte membrane undergoes a reaction called the cortical reaction, so that there will not be polyspermy. So then as the sperm enters the secondary oocyte, remember the oocyte will undergo and complete its meiosis. Remember it stopped in meiosis 2. So it continues its meiosis 2 transformation, forming the ovum and the second polar body. So when the ovum is then formed, the two what are called now pronuclei, so that's not just a nucleus, they're called pronuclei because they swell. They migrate towards each other, and there's actually a mitotic spindle that forms, which remember is going to draw chromosomes towards each other. So in this case, the moment of fertilization is when the male and female pronuclei mixed together. So it's not, so fertilization, to recap, is not when the nucleus enters the oocyte, it's when the two chromosomal materials from the male and female mix together. And this is what is called and defines a zygote. So when you see the word zygote, you know that that is going to be both the male and female chromosomes that have mixed together. The zygote is depicted over here in this picture. So we see that fertilization takes place all the way down towards the distal side of the tube, the uterine tube. Then, as it starts to travel towards the uterus, we undergo divisions. So you see in step number B there, this is approximately 2 days. The cell has divided into 4 cells. Then, just within another day, it is now divided into 16 or so, whereas then when it becomes D, now it's not just a solid mass anymore, it's a mass of cells in one side, and we can see a space that's forming over here. So this is called the blastocyst cavity, and it's called a blastocyst, the whole thing. And this blastocyst, let me write it up here, this blastocyst is what is going to be implanted into the endometrial wall. This implantation is going to take place approximately 6 to 7 days after ovulation, and when this happens, there's usually an inflammatory-like response that occurs in the endometrium that involves blood vessels becoming more permeable, inflammatory cells, and whatnot. So you can look through the book and you can see that there are several long names for this blastocyst. Then as it implants, trophoblasts, cytotrophoblasts, insidiotrophoblasts. You see all these names. You don't have to be familiar with these names. Undergoes these changes, though, as it is embedding itself into the wall. So remember that the corpus luteum was important. We talked about the corpus luteum last chapter. The corpus luteum is going to secrete important hormones, progesterone and HCG, human chorionic gonadotropin. So these two hormones will be important because they are going to prevent menstruation. Because what would happen if this woman menstruated? Okay, there goes the implanted zygote. So if implantation takes place, it really is what defines a spontaneous or natural abortion. The woman won't even know that she at one point was pregnant, though. So in this particular image, we're going to see the development, the process of what's called placentation, which is the development of the placenta. So we see in this 7.5 day, what's called a blastocyst again, we can see the blood vessels start to becoming leaky, start to invade this area, and just in a short period of 5 days, we see that it starts to grow even more. And in this particular image, part B, we can actually see, now this is going to be us right here, the growing embryo. So you can see the growing embryo there, and then obviously big time here, and in the last picture. But then you also see the growth of the placenta in this picture. So there's going to be two really important structures that make up the mother and both the fetus, the embryo/fetus portion of the placenta, and then also the maternal portion of the placenta. So we have in the maternal portion of the placenta two structures with the name decidua. Decidua basalis and capsularis, which you see in your book and in your PowerPoints. And these are going to be important because this is how the placenta will expand and accommodate the growing fetus, but also where the blood supply is going to come from as well. So if we take a closer look at picture D there, you see that the decidua portion, which is out here, and then inside the fetus, you're going to see these little parts right here, okay, and these are called the chorionic villus. Chorionic villus. Remember, villus means finger. So these chorionic villi are important because they go up into the tissue. And you notice if you take a real picture that the blood supplies do not mix. Remember that the maternal, okay, and the fetal blood supply are not the same blood. So the mother has her own separate blood supply than the fetus. The fetus has its own blood supply. They come in very close contact with each other, and this is how nutrients, wastes, oxygen, CO2 diffuse from one portion to the other. We talked about it way back when, that the fetus has a special type of hemoglobin called HEF. Okay, that's important because it has a higher affinity for oxygen than the mother's bloodstream, so that it will literally steal oxygen from the mother's blood supply. Then in the last picture, which is approximately 13 weeks, you can see that this kind of whole package just really organizes itself well to where we have the placenta on the outside. Okay, still have the decidua basalis and the chorionic villus, but you see that the yolk sac, which is this yellow portion, really whittles down to almost nothing there. And there is clear definement of now what's called the amnion. So the amnion is the sac which holds the fetus, and you also see the fluid, the amniotic fluid cavity inside, which is made of, like I said, amniotic fluid, but later the amniotic fluid is mixed with the child's own urine. It's kind of gross, but at some point in all of our lives we were literally floating in our own urine. Now this particular image actually shows the germ, what are called the germ layers. So we come from three general layers. They are called the scleroderm. Can't spell. Scleroderm, myoderm, and ectoderm. Okay, and these three germal layers, they're actually a subcategory of ectoderm, endoderm, and mesoderm. So we'll see here in this particular image, if you're looking in your book, that sorry, I got ahead of myself here. These are the three layers that you see down here. So the ectoderm is the blue. Okay, the mesoderm is the yellow. Okay, and the endoderm is red, and the endoderm is the yellow. So those are the three general layers. And so we see those same three colors as we look through the process of this. And this is only 16 days, so we are at this point still not very old. Now the process of organogenesis. So organogenesis literally means the beginning of our organs. So we undergo this around week 8. Organ systems become recognizable. Like it says, we start as this flat plate. Okay, we start as this flat plate of cells, but then we develop into the cylinder, and that will then begin to fold over each other. So you can actually see in this picture the head and the tail, so literal cranium, coccyx, and that will begin to differentiate into the different body tissues. So this is kind of what I was getting at earlier. I was getting ahead of myself. The mesoderm has a specialized area where sclerotome, dermatome, and myotome are going to be three functional parts. The sclerotome is going to be responsible for forming our vertebrae, okay, and our ribs at each level of our spine, whereas the dermatome will then form both the skin on the dorsal part of the back, the dermis, I should say, so the dermal portion of the skin. And remember that the dermatomes also can be seen in a map drawn that we learned way back in chapter 13, whereas the myotome will form the skeletal musculature. Okay, so those are going to be important for the development of, and there's 40 pairs of them going from top to bottom, so that's going to be visualized when we see the different levels of our spine. So if you remember all the different C1, C2, all the way to the coccygeal region, there's 40 different levels there. So we look at specialization of other tissues. Mesoderm is also responsible for the gonads and the kidneys. Figure 28.12 in your text, if you want to turn and look at that. shows where each of the colored, so these are going back to that same colored coordinated system that we saw, layers of tissue, or layers of cells I should say, blue, red, and yellow, shows where each of our body parts originates from, which layer they come from. Remember that the heart beats at 3.5 weeks. It forms from a pair of tubes that eventually winds into an S shape that will then eventually become the heart that we know. Remember that also there are modifications during prenatal development that eventually will close after birth, including the umbilical artery and vein, umbilical veins, and then we also have vascular shunts. So shunts, remember, is a way to move blood from one place to another. Vascular obviously means blood. So we have the ductus venosus, which bypasses the liver, the foramen ovale, which is between the two atrial septa, the two atria in the septum, I should say, and then the ductus arteriosus, which bypasses the pulmonary trunk. So it goes from the pulmonary trunk into the aorta. And remember, the whole purpose of these shunts is because we don't fully need to bring blood to the lungs, because our lungs aren't operating yet when we are prenatal. And also for the liver, a lot of the detoxification comes from the mother. So our blood is going to basically diffuse its waste into the mother's blood, and then she will get rid of them for us. So by the end of week 8, which is the embryonic period, bones begin to ossify, muscles are forming and contracting, the lungs and all the organs are developing, the heart and the liver. So basically all the organs are present by the end of week 8. They're not fully functioning yet, but their development is present. Then through weeks 9 to 38, the fetus now undergoes rapid body growth, much more so than initially, changes in appearance and in dramatic fashion. So even though the greatest amount of growth occurs in the first 8 weeks, the periods from week 9 to 38 is a rapid body growth time. So if you look in your textbook, there's an actual chart or table, 28.1, that details from 8 weeks then through month 3, month 4, month 5, 6, 7, and 8, 9, all the different details of what happens during fetal development. So you want to go and take a look at those tables to see what's happening in the fetal period. When talking about the effects of pregnancy on the mother, one of the first signs of pregnancy is called Chadwick's sign. So it's a visual inspection of the vagina where it has a purple hue. So back in the day, there was obviously no blood testing and whatnot. So this was a sign that was developed, or a sign that was discovered, that you could tell if a woman was pregnant by the color of the inside of her vagina. Also, the breast will enlarge, the areola will darken upon pregnancy, and there will be possible pigmentation or changes of pigment in the face. Many different things happen. So you see here this picture of how the uterus eventually will expand, occupying most of the abdominal cavity at some point. You notice also her center of gravity is going to change, so she's going to have increased lordosis. Remember, lordosis is the curvature of the lumbar spine. And the uterus can potentially reach the xiphoid process. Remember, the xiphoid process is all the way up in the sternum. So it's a large change. As she goes through her pregnancy, she's going to release a hormone called relaxin, which is going to help to relax the ligaments and the pubic symphysis to try to reduce tearing upon childbirth. Obviously, weight gain happens, and nutrition will have to be watched, and typically pregnant mothers are going to have to increase their daily caloric intake. It's interesting, I hear people say, oh, well, I'm eating for 2, and I'm like, well, actually, you're eating for like 1.2, but go ahead and eat double, that's cool. Many doctors are going to put mothers on prenatal vitamins to make sure that there are no deficiencies. Many of our neurological diseases and also spinal problems have been determined or been linked to prenatal deficiencies in certain vitamins. So some other changes that pregnant mothers are going to notice is that different hormones such as HPL, human placental lactogen, and human chorionic somatomamotropin is going to be secreted in order to stimulate maturation of the breasts, but also fetal growth, and glucose sparing for the mother, sparing in the mother, meaning reserving glucose for the fetus, and this can cause what's called gestational diabetes for the mother because of this glucose sparing of her child. Usually this glucose imbalance goes away after birth. But also PTH, parathyroid hormone, and vitamin D levels are going to attempt to be held high during pregnancy to ensure adequate calcium. Remember that you're building an entire fetus within your body, meaning you have to build bone as well. Where is that calcium going to come from? It's going to come from you. So if you don't intake your calcium, if you don't have proper intake of calcium, increase your calcium intake, the fetus is literally going to steal calcium from your bones. And a lot of mothers do have teeth problems, and it's ironic that of all places calcium is taken, a lot of mothers describe teeth problems during pregnancy. Calcium is pulled from teeth, so it's very important to maintain high levels of calcium to try to prevent this from happening in order to create proper bone mineralization in the fetus. Now, GI system, many of you probably experience morning sickness, heartburn, constipation. These are common, and also urinary system. Increase urinary output as you move through second and third trimesters. Increase because you are increasing your own metabolism, but remember that you're also secreting the wastes for your fetus as well. So frequency increases, meaning how often you have to go. Urgent urination, meaning I have to go now. And stress incontinence, meaning your bladder is being pushed on. So easy things that you do, such as, coughing, laughing, maybe swallowing even can cause urinary incontinence. So meaning you might have a little accident as the bladder is compressed. Respiratory system changes include increase in tidal volume. Remember, tidal volume is the normal volume in one breath. So that's going to increase because you are having to intake more oxygen. Dyspnea may occur, difficulty breathing later in pregnancy just because the uterus is directly under the diaphragm. So if you're trying to take a deep breath, there's literally nowhere for your lungs to expand to. So taking a deep breath might be difficult. The largest change that happens, though, is in the cardiovascular system. The blood volume increases 25 to 40% to safeguard against blood loss during childbirth. So it's like your body knows that it's going to undergo this blood loss due to pregnancy or due to childbirth. So you produce more blood. Cardiac output can rise as much as 35 to 40%. And this in turn creates varicose veins in the lower leg specifically. Remember, varicose veins are veins that are seen superficially because of impaired venous return to the heart. So if there's more blood in your system, and remember that the venous system is a blood reservoir, over 60% of your blood resides in your veins at any given time in your body. And since that's increasing, it might cause varicosity as well. Now in your book and in your imbalance slides, you're going to see a teratogen, factors that cause severe congenital abnormalities or anomalies, and even fetal death if harmful substances cross the placental barrier and enter fetal blood. So specifically we talk about fetal alcohol syndrome. Pregnant women who drink alcohol cause the fetus to become inebriated, literally getting your fetus drunk. But fetal consequences may be longer lasting, which includes small head, intellectual disability, and abnormal growth. Also, nicotine, so smoking, hinders oxygen delivery to the fetus, which can also impair its growth and development, as do many types of drugs. So as you probably know, you need to consult your doctor if you're taking medications and you become pregnant. Preeclampsia is a condition that can result in deterioration of the placenta which can lead to the child being hypoxic. So the woman, typically the pregnant mother, is going to become, she's going to have edema, she's going to have high blood pressure, and she's going to have protein in her urine, proteinuria. Usually affects about 10% of women. In the process of labor, so there are different stages of labor. So parturition is the technical term. So if you ever thought about the word parturition, and it's where we get the word postpartum, if you've ever heard of it, postpartum. Series of labor is different steps, so we'll talk about these steps here. Moms, as you know, the fetus is supposed to determine its own birth date, but as we know, we have medications now that can induce labor and whatnot. So it's all based on hormones in the mother's blood. And typically, in the few weeks before delivery, the fetus is going to produce surfactant, protein A, which is going to trigger an inflammatory response in the cervix, causing it to soften and prepare it for labor. Because if you think about the normal size of the cervix and how much it has to stretch for the child to pass through, it's pretty big. So the estrogen effects can cause the myometrium to be prepared. And also, this is where ladies, where you, if you've been pregnant, you maybe had false labor contractions called Braxton Hicks contractions. So they're not true labor contractions, but it's all in preparation for the main event. So with oxytocin is going to be an important hormone. Oxytocin and prostaglandins are going to be the uterine muscles, so the myometrial stimulants, and they're going to help initiate contractions. And then oxytocin is going to help to make them more frequent and vigorous. It's positive feedback cycle, if you remember. So increasing the cervix size, the distension. So if you ever have been around someone who is giving birth, they're going to talk about the dilations. They're talking about the cervix dilation, distension. And so when the oxytocin and the prostaglandin act, then it activates the hypothalamus, causing oxytocin to release from the pituitary gland, which then causes more uterine contractions. This is a positive feedback cycle, which eventually will end with the child being born, so going into actual labor. So the stages of labor. So this is 1A in your book. This is early dilation. So you see that the baby needs to be in a proper position. So we'll talk about normal position versus a breech position in a minute here. But this is the longest stage of labor. This is the dilation stage. This is when the contractions are pretty widely spread apart, and they don't last very long. But as you move forward through the stages of labor, it becomes more powerful and more frequent. This is when the amnion also ruptures, releasing the amniotic fluid. Engagement occurs, meaning the head is now entered the pelvic region. So in late stage dilation, which is 1B over here, the baby's head rotates so that the widest dimension is in the pelvic outlet. So this is important because this is going to allow birth to happen in a more natural way. Whereas if the baby is turned, it's going to be more difficult for it to be expelled. So dilation is nearly complete in this particular stage of labor, late dilation. And then 2, the expulsion stage. This is the stage that goes from full dilation until delivery. Strong contractions every 2 to 3 minutes, each lasting about a minute. And so you see crowning is when you actually are looking and you can see the head. You can see the head distending through the vulva. So you know that this is going to be happening very quickly now after this. Episiotomies often are done. I hear that they don't really do them as much anymore, but episiotomies, which are incisions to widen the vagina, so literally cutting of the vagina to reduce the amount of tearing. That's kind of debated now whether that's, it's usually up to the clinician or the hospital to determine what their policies are regarding episiotomies. So obviously the baby's neck extends, so you can see that the way that the baby comes out is a natural way, and if the if the baby was coming out feet first, it would be a lot difficult to come out feet first with the arms flailing. So the way that it is naturally designed to come out is head first, facing down. This is called vertex position. If it is coming out feet first or buttock first, this is called breech. And so this is definitely more difficult. Sometimes you can go to doctors, chiropractors, or physical therapists beforehand to try to get the baby to turn naturally before birth. But if not, C-section may have to be done. Or C-section, cesarean section, is having to cut into the abdominal and the uterine wall to pull the baby out. Stage 3 is all about the placenta. So we see stage 3 here, or the afterbirth. Occurs usually within 30 minutes after birth. The contractions will continue, causing detachment of the placenta and the vessels. And this is important. The placental fragments, everything needs to be removed, because if not, it can cause postpartum bleeding. Then, if you guys know anything about the placenta, people actually take them home with them. You can eat them. You can have them compressed into a pill. If you actually go over to Google, you can type in placenta recipes. I'm not joking. And there are different ways to prepare the placenta. So why would you want to do this? Because it's said that the placenta is one of the most nutritious things that you can possibly eat. So when the baby is born, it's pretty much a shock. Think about the fact that you've been living in this warm, dark, wet environment for the past 9 months, and all of a sudden you are exposed to light for the first time. It's cold, it's dry. So you imagine that it's actually pretty traumatic, and thank goodness that we don't remember this experience. The physical status of the child is assessed within 5 minutes. It's called the APGAR score. Okay, APGAR score. And it's given 0 to 2 points for each of the following categories. So heart rate, muscle tone, respiratory rate, reflexes, and color. So obviously the heart rate is going to indicate that the heart is beating. The muscle tone is going to indicate that the baby has proper movement. The baby's able to move, not paralyzed. Respiratory, obviously, is it breathing? Reflexes, so tapping on certain reflexes to see if there are neurological reflexes intact. Color, another thing related to breathing, making sure the baby doesn't come out and it's purple, because obviously that means that it's not breathing. So it's often said that if the baby's crying, that's a great sign, because you know that the baby's lungs are working. That first breath is said to be the very first breath is said to be the hardest breath in life that we will ever take. So taking the first breath and transitioning, CO2 isn't able to be removed by the placenta anymore, so the levels rise initially. So that has to stimulate our respiratory center to trigger that first inspiration. Airways are tiny, the lungs are collapsed. Think about the lungs are collapsed, and they will never be again collapsed for the rest of our life until we die. So having to inflate them that first time is very difficult. And remember that surfactant, which helps to reduce the alveolar surface tension, is important. And typically babies that are born prematurely, they're not going to have a lot of surfactants. They're going to have to be put into a breathing chamber in order to help them breathe properly. So the respiratory rate amongst newborns, the first couple weeks of life, is really high, 45 per minute. And if you remember, the normal rate for an adult is around 10 to 15 breaths per minute. So they're breathing at a rate about 3 times faster than us. So then when we're born, we go through a transitional period where we have activity, sleep, vital signs are irregular. Typically the baby's going to gag a lot, and it's going to have a lot of mucus and debris inside of its esophagus and inside of its airways. So there's going to be some things that you'll notice. Now, when we go and look into, first of all the different shunts that we talked about before, they all close. So the foramen ovale becomes the fossa ovalis, and the ductus arteriosus becomes the ligamentum arteriosum. So you look at your text, it'll tell you all the different names of things that change. During the first 2 to 3 days of development, though, and specifically with the mother, she's going to produce a special type of milk called colostrum. So this is going to be an important one to know. Colostrum, it's going to be different than true milk. So it's going to be kind of a yellowish hue, and it's going to be full of protein, vitamins, okay? And it's going to also have a lot of IgA antibodies. So she's going to be passing, remember we talked about passive immunity way back when? So this is a way that the mother can pass immunity in the form of antibodies so that the child who has no immune system initially and is going to immediately start developing its own immunity, but this is a way to give your child some immunity, and it's resistant to digestion, so it prevents, so it protects the baby from bacterial infections. After 2 to 3 days, though, this colostrum is going to change, and then true milk will come. And there is now, don't forget, there is IgA in true milk as well. It's just not as high of a percentage. So to breastfeed or not, there are proven advantages to breast milk. It's better digested than cow's milk, and that the formula that you see in the store, it has the IgA antibodies, it has other beneficial chemicals, some inflammatory response chemicals that are important, some glycoproteins which deter H. pylori from attaching to the stomach. It also encourages bacterial colonization in the gut. So I don't know if anybody's done any research about bacterial colonization, but a lot of disease has been related to the bacteria of the gut, of the intestines. So with the breast milk, there is a natural laxative effect that helps to cleanse the bowels of what's called meconium. So meconium is this kind of tar-like greenish black feces. It's kind of a waste, but it's a waste, but it's a combination of fecal matter plus cells that the child. Remember, this is basically the first bowel movement. So it's going to look different than bowel movements for the rest of your life. So this first bowel movement, since the child's never technically eaten anything, it's going to look a little bit different. It's going to have bile in it, and so it needs to be eliminated, though, because if it doesn't become eliminated, it can cause jaundice. So since it has a lot of bile in it, if it's not expelled, then that bile will be broken down. And remember, the pigment turns the skin and the whites of the eyes kind of a yellowish hue. The last part of the text in the PowerPoints talks about assisted reproduction technology, abbreviated ART. So you guys can go through and look at that if you like. It talks about in vitro therapy, assisted reproductive therapy, and different types of fallopian transfers. And then also the whole issue of cloning. So they're obviously legal and moral and political, all kinds of roadblocks to cloning, and maybe it's religious. So, but it is the future, and we are often looking at stem cells, our own stem cells, to see if we can use them in positive ways. So that concludes this Show Me on pregnancy and embryology. Next chapter, final chapter of the book, we've gotten to the final chapter of the book, can you guys believe it, is on genetics.